Now it is better.
Yes, yes, yes. ऊपर भी स्क्रीन दिए है, अब नीचे भी करो कि लेफ्ट। रजनी मैम इज वेटिंग, प्लीज एंटर।
जी सर।
पुणे लोकेशन एक बार चेक कीजिए नितिन सर।
अच्छा, रांची एक बार चेक कर लेते सर।
हाँ करते, रांची भी
हेलो।
करते हैं। पुणे चेक कर लीजिए नितिन सर, थोड़ा सा
हाँ
नितिन सर को अनम्यूट कीजिए।
सर, नीतीश सर को एडमिट है तो।
नहीं नहीं, अनम्यूट अनम्यूट।
हाँ नीतीश।
also and in the
Yes.
slides also.
Perfect.
And besides that, there is one seventh center at Kolkata
Yeah.
where there will no moderator. So requesting you to just take a couple of questions on their behalf also.
I'll show you.
Yeah, yeah. And Dr. Christoph Gesh was also there.
Yes, good evening, sir.
I'll just ask him to connect again.
Good evening from India.
So you will be sharing your screen with the presentation, or
You're asking me or sir?
yes sir, yes sir.
No, it's okay. In fact, we can be just like that if it is okay, all right for you.
Yeah, Ramnath, if we have the backup ready, then we can start with that also.
Yes, Pratik sir.
You may count down so that we'll be ready. हाँ जी सर बताइए.
Yeah, Ramnath, you are on mute.
हेलो प्रतीक सर.
हाँ जी सर बताइए.
हाँ, डॉक्टर मंगेश का पीपीटी जरा शेयर कीजिए ना.
या अवधेश.
His presentation
If
can
Dr.
you
Divascar
display?
is okay to share from his system, that also would be fine.
Sir, totally.
That is,
No issue at all. I'll share.
yes, that would be better.
I'll share. Don't worry about it.
Okay, fine.
Just give thumbs up, Pratik sir, when we are about to go live.
Dr. Chris is there. Chris, right?
Yes, I'm here.
Yeah, yes sir. Yeah, hi. Thanks. Yeah. So this is that introduction presentation, and that includes the 6 slides of the 6 local moderators also.
Okay.
Yeah. Dr. May I introduce you to Dr. Mangesh Devaskar? Sir, Professor Chris is here.
Good evening, sir.
University
Namaskar.
of Vienna.
Yeah.
Yeah. And Dr. Mangesh Devaskar will be the moderator for the today's session, sir.
Yeah. I think Sanjay, the presentation that you have shared does not have that the other moderators' details. So I would request you guys to share that presentation straight away so that it will be really easier for me.
Oh, yeah, this is the old one then you are. Today
this
I
is-
sent you today only that presentation.
Asha, you have WhatsApp me or you have emailed me?
Both email as well as WhatsApp.
Okay, so I'll check.
But then,
And I'll
yeah,
request that it would be better if you can share it from the presentation
Okay.
side so that there is no
Okay.
confusion. Okay.
yeah, sure.
Okay.
Hello, yeah. Ramnath? Ramnath, you are on mute.
Yes, sir, I'll share from my side, sir.
Yeah, and sir would like that new presentation with the details of 6 local moderators and all to be flashed here.
Yes.
Perfect.
Yeah, he has that earlier presentation without the details of those 6 local moderators.
Fine, I'll share, no
Yeah,
issues.
yeah.
But Chris, we were there last month in Vienna for an ESD conference. We really loved that place.
Last
Yes.
month in November.
Yeah, just end of October and November. There was a international European Society of Diabetes conference, ESD, that happened at Vienna Convention Center. So we were there.
I hope you enjoyed it.
Yeah, really, it was beautiful.
Yeah, my screen is visible?
Yes.
Yes. Pratik sir, are we live?
So give us a countdown so that we'll go.
You just change the slides and see once.
Yes, sir, we are live. Perfect.
Yes.
Yeah, Sanjay, we are live, so probably we may start.
So the
It's 9
script has
o'clock.
been sent to you. You need to welcome the delegates and start.
Yeah, so shall I start? It's,
Yes.
if you want to.
Welcome, sir.
Yeah.
Please.
Yeah. Okay, so are we good to go live? Good evening, everybody. I am Mangesh Tivaskar. Yes, so good evening, everybody. I am Mangesh Tivaskar, and welcome to today's very, very unique webinar, I would say, international speaker program on the new perspectives on the ferric maltol. Now we have heard different combinations, we have used different iron therapies to manage anemia. But let me tell you that this ferric maltol is one of the kinds that has really impacted the way we manage anemia, especially iron deficiency anemia. We do have here with us today one of the legends in the iron therapy management. He is Professor Christoph Gasch. I hope I have pronounced his surname correctly. Christoph sir is one of the legends who has really published his original work in this molecule. Now, to welcome all of you, let me also tell Dr. Christoph that we have been joined today from 7 different locations all over India from our country. It is Behrampur from Odisha, Pune, Warangal, Jorat, Jaipur, Ranchi and Kolkata. So thank you for being there with all of us. Now, if you really look at today's session, we will be trying to focus on a relevant daily clinical management pearls that we want to hear and learn from you on iron and inflammatory disorders. And in that perspective, what are the new things on ferric maltol? Now, especially in India, if you realize, iron deficiency anemia is extremely prevalent. In fact, that is one of the most commonest illness which is neglected all over India. And especially when it comes to women, almost 8 or 9 out of 10 women are anemic. And the commonest cause is iron deficiency, we all know. And generally these diseases, iron deficiency exists with a lot of chronic inflammatory conditions. And they impact the patient outcomes that we are all aware about it. Commonly presenting with fatigue, reduced functional capacity, decline in the quality of life. All those things associated with inflammatory conditions like irritable bowel disease or the inflammatory bowel disease, chronic systemic illnesses, including the chronic non-communicable diseases like diabetes, hypertension, and also very active inflammatory diseases. They all have some role to play when it comes to iron metabolism and iron deficiency. So we are sort of trying to evolve our understanding about the inflammation-driven changes related to iron metabolism and what are the new therapeutic options which are emerging like ferric maltol. So to address this, I am greatly honored to introduce today's one of the champions and the esteemed international speaker, Professor Christoph Gasch, Director of Loha for Life. You know, Loha is again a Sanskrit word for iron. In Indian culture, we use it in Hindi, Marathi, and a lot of regional languages also. Loha in Sanskrit is iron, and I am more than sure that the name for his center, Loha, has been inspired from Sanskrit. The Center of Gastroenterology and Iron Deficiency and Management, Vienna. He is a professor at Medical University of Vienna, Austria. He is a board-certified clinician, an internal medicine champion, and also he is a board-certified gastroenterologist. And he has completed his training in the molecular oncology at University of California, San Diego. Friends, Professor Gasch is globally recognized for his groundbreaking work in iron deficiency anemia and gastrointestinal disorders. His contributions include classification of Crohn's disease, his major achievements in the inflammatory bowel disease, immunogenetics, inflammation associated colorectal cancer, and chemo prevention attracted the global audience to hear him. He has more than 100 international publications. He has written 6 books 27 chapters in different textbooks, and he owns 4 patents. Now that is remarkable. He is extremely well heard clinician across, and we all are extremely privileged to have him with us today. So friends, I am Dr. Mangesh Tivaskar. I am a physician diabetologist at Shilpa Medical Research Center in Mumbai. I also am lucky enough to shoulder the responsibility of being the editor-in-chief of Journal of Association of Physicians of India, that is JAPI, which is one of the most highly well-read journals in the Indian subcontinent. This education partnership comes with Aristo Pharma, so thank you very much Aristo Pharma for giving us this opportunity to hear from one of the legends of the subject. And together we have Sanjay Shroff from our management team from Medica Press and his team to actually conduct this webinar. Quickly, before we start, Dr. Gash, I'll just introduce the moderators from our local centers. We have Dr. Deepak Kumar Pushti, a general surgeon over 30 years from Behrampur, Odisha. Dr. Dhyanuba K. Bhaskar, he is a consultant physician and diabetologist from Pune, Maharashtra. Dr. V. Chandrasekhar, Director of Medical Education and Superintendent at GGH Mulugu Hospital from Warangal. Dr. Sujoy Baruha, consultant gynecologist and a laparoscopic surgeon from Jorhat, Assam. Dr. Madhulika Agrawal, she is a senior consultant in obstetric gynecology from Jaipur, Rajasthan. And Dr. Beauty Banerjee, she is a general surgeon from Ranchi, Jharkhand, and I would take care of a Kolkata center. So handing it over to Professor Christoph Gash, I invite him to take us through his talk on iron and inflammatory disorders, new perspective on Ferric Maltol. Over to you, Professor Gash. Thank you very much. Stage is all yours.
Dr. Mangesh, thank you very much for introducing me. I'm not so important, but I'm trying to advance the field of iron deficiency in gastroenterology since I'm very young. And I will show you a couple of very old slides, very old work together with the latest work on iron maltol, which is the topic of today. I became interested in iron through inflammatory bowel diseases, and this is what I'm going to show you in the next couple of minutes. I will talk about iron deficiency in IBD. I will give you some insights into our IBD mouse models. I will a little bit go into alternative iron products. Iron EDTA is part of food supplementation, and I will give you some data on that in comparison to ferric maltol. And then I will end up with the clinical IBD trials on ferric maltol in IBD-associated anemia, the so-called AEGIS trials, and I will end up with showing you the safety profile of this product that really changes IBD iron management around the world.
So was I right to say that your name of the center Loha is being inspired by the word Sanskrit Loha, that means iron for us?
That is very correct, and I will point you to the person who invented this name at the very end of my talk. Yeah, I have a co-worker for many years, and she's from India, and she came up with that name. So yes, you're perfectly right. That is correct. Lower means iron. IBD has a lot of complications, and the most extra-intestinal complication is anemia. Anemia in IBD is multifactorial.
Professor Keshav, sorry to interrupt, your screen is not share your screen.
Your slides are not shared, sir, I believe. So you'll have to share your slides.
Once again, yeah, please.
Okay, let me try to do that. I did share my slides before, but I'm trying to share it again. I'm sorry. Can you see it now?
Yeah, they are coming up, sir. Yeah, now we are able to see it. Yeah,
Okay, I'm sorry.
perfectly fine, sir.
Thank you. I was introducing you to the structure of my talk about IBD, IBD mouse models, and about clinical trials with Ferric Maltol. And I was talking about IBD itself as anemia itself as the most common extraintestinal complication of IBD. And the main cause of anemia in IBD, and we'll go into detail about this, is iron deficiency. This is basically studies out of the late 80s and early 90s which we conducted. The second cause is inflammation, and I will go a little bit into the molecular details of that. Of course, there is also nutritional deficiencies. I guess in India as well as in Austria or Europe or United States. We use also medications that impair the bone marrow and can cause anemia, such as azathioprine. And there is a rare causes of anemia, such as hemolytic anemia, but these are the rare causes of anemia in IBD. Anemia is associated with disease activity. Everybody thinks because it's associated with disease activity, this is due to the inflammation. No, it's mostly because disease activity comes with ulceration, and ulceration is seen on the right-hand side. Typical ulcerations in Crohn's disease below, and ulcerations in ulcerative colitis. I don't need to show this to you. Everybody knows these pictures from endoscopy. And these ulcerations are causing bleeding, and bleeding is causing iron deficiency. And anemia itself is highly neglected as a disease, as it is so common. You're mentioning iron deficiency being very common in women in India, and they're probably used to this iron deficiency anemia, but it adversely affects quality of life. You mentioned fatigue as one of the most important symptoms. And once more, I will show you that anemia is recurrent. It's not a single one stop that you need to treat. It's a continuous issue that you need to take care in your patients. So this is where everything started off, and I will point you. I'm not sure whether you can see my arrow, but this is here in 1994, published in 1994 in Digestive Diseases and Sciences. This was basically the first work I did in anemia. On the cause of anemia. And the question was, is it more iron deficiency or is it more inflammation? And we studied about 450 patients with IBD, exactly 49. 16 were anemic and 33 were non-anemic. And we compared, the clinical activity, the C-reactive protein, other inflammatory markers like alpha-1 acid glycoprotein. And we studied iron parameters and erythropoietin. And we came up that the most important issue here that was significantly different was ferritin. Ferritin was significantly lower in patients with anemia compared to patients with no anemia. Anemia also comes with erythropoietin increase. There was an erythropoietin increase, but we considered this increase inadequate to the severity of anemia. I also mentioned that anemia is very prevalent. The studies are varying between 36 and 90% in the IBD population. And I also mentioned before that blood loss from the ulcerated mucosa is the main cause of iron deficiency. However, there is also reduced uptake, and this is important when we think about oral iron therapy. And there is also impairment of the uptake. And the most important issue is that there is a persistent negative iron balance, which means that you're losing more iron over the ulcerated surface of the intestinal mucosa than you are able to take it up, to absorb it. And last but not least, the products that were on the market in the past are also all ferrous products, Fa2+ products, and these products cause intolerance, very commonly in IBD population, and also inefficacy. This was the reason why we started our first interventional trial with an IV product. This was an old drug that was available since the 70s called Ferric Maltol. It's an iron sucrose or iron saccharate. That's the same thing for this same name for the same thing. And what you can see here on the response curve is that on the dashed line, this is iron treatment only. 80% of the population was responding to IV iron therapy. And if you combine it with erythropoietin, it's almost 100% that responded. So we were very glad about this effect. This study was followed by a couple of review articles. I don't want to go into details. I was in the position, or I was asked to get into the position to write a couple of guidelines on the diagnosis and treatment of iron deficiency anemia in IBD, with many international co-authors, and this was basically, and we also developed a couple of other intravenous iron products such as Ferric Maltol, and we also developed new treatment guidelines regarding the dosing of these IV products that became more commonly used in IBD in Austria and Europe. What is the problem with ferrous iron uptake and also iron uptake from food? The main problem is that iron is absorbed mainly in the duodenum and upper jejunum, and if you take ferrous iron in a dose of 100 to 200 milligrams a day, it's only 10 milligrams to max 15 milligrams that are absorbed here. The rest of the iron passes through the small intestine and passes through the large intestine, and thereby it passes the area of inflammation. And when it passes the area of inflammation, this ferrous iron reacts to ferric iron and produces reactive oxygen species. This is something that ferric iron itself cannot do anymore. This is, I think, one of the reasons why Ferric Maltol is has much less side effects than ferrous iron. Side effects, in IBD we have a lot of diarrhea, but in other patients like women there's a lot of constipation, but most importantly it's abdominal pain, and many think that this abdominal pain is gastric pain. Then they combine it with a PPI, which I don't think is a good idea because this reduces absorption. You need the acid to absorb iron in the duodenum. So if you combine it with PPI, don't do it. It doesn't increase efficacy and doesn't reduce symptoms. This seems to be a complicated slide, but let me lead you through that. I mentioned that iron is taken up in the duodenum, and this is a very specific process that is taken up over certain molecules. Iron is from the duodenum, goes into the circulation, is bound to transferrin, and actually if you measure the amount of iron that is bound to transferrin, it's only 3 milligrams for the total body. So the iron that circulates on transferrin is minimal to the iron amount that is in the body. The total iron amount in the body is in the grams. We talk about 3 to 4 grams in an adult human. But over the transferrin, iron goes to the bone marrow, leads to erythrocyte production, and erythrocytes live for about 120 days. They get destructed in the spleen, go into macrophages, and then iron should be released back and recirculate into transferrin and being reused. It's a recycling mechanism that is very important, and it's about 20 to 25 milligrams per day that are recycling compared to this 1 to 2 milligrams that are absorbed. So the recycling is much more important than the absorption when it comes to iron metabolism. However, during inflammation, the liver builds a peptide called hepcidin. This hepcidin has certain effects. During inflammation, it blocks absorption, it blocks the release from the recycled iron, and it blocks the release from iron from the liver, and this leads to a reduced transferrin saturation, to reduce plasma iron, and to reduced iron in the circulation. I'm sorry, I'm a little bit under the weather and my voice. If I get a cough, I apologize. I can't be contagious over Zoom, but yeah.
You don't worry, Chris. We are good to go.
This is the first study actually from 1998 where ferric Maltol was tested in humans. This is non-IBD population. And you see individual improvement on Ferric Maltol. The important question in this study was, is it absorbed? And yes, it looks like it's nicely absorbed. Also, the ferritin increases over time. This is a study over 3 months. The same group tested absorption with different chemical formulations of Ferric Maltol, and they saw that all the chemical formulations they used actually are nicely absorbed. So it looks like the absorption of ferric iron does also work. We started working with Ferric Maltol in mice. Here we were actually interested in the toxicity of iron sulfate, which we commonly use in IBD populations, and wanted to compare this to Ferric Maltol. We also used a plant iron, which actually was also produced in India and came from curry leaf extract from India. And finally, we compared it to iron EDTA, which is basically the main iron you find as a supplement to food. I don't know about India, but in Europe and in the US, certain food is supplemented with iron because iron deficiency is a very important issue, and so supplementation with iron takes place. So this is a food supplement, nutritional supplement that is added to food such as cornflakes, butter, spreads, various forms. And we thought, this must be super safe. This we're interested to study. This is our product that we know, and the plant iron, we don't know how it works, and we also test. Interesting on that picture is also that iron in different formulation looks very, very different from green to orange. So iron is not iron. Iron is a very diverse metal. On this busy slide, I will lead you through. Just focus on the left column here. We added these 4 iron products to the food of mice in a so-called AOM DSS model. So mice received DSS on 4 different occasions for 5 days, after 2 weeks, after 4 weeks, after 6.5 weeks, and here at the end. And DSS induces inflammation in the gut, and this inflammation you can see here with the disease activity score going up. Then you stop the DSS, the disease activity score goes down, and you add DSS, disease activity goes up, and then it goes not as much down as at the beginning because it was a second circle, and here's the third circle. On the last circle, the mice were sacrificed. One curve is going up and staying up, and these mice were very, very sick. And in these very sick mice, I need to, sorry, oops, because I have here, no, it's better. These mice were the EDTA treated mice. If you compare this now on the mean CD DIA, disease activity score, you see it's significantly higher in the EDTA mice. If you look into the histology, it's significantly higher. And also if you look into tumor burden, the mice received AOM at the beginning. They also have a very large amount of tumors. We were not able to really believe that. It was very unusual to us that the food supplement is so toxic. And so we used the second mouse model, the IL-10 knockout model, to replicate these data. And you see again, in the IL-10 knockout mice, the disease activity goes up on EDTA, stays up, and stops here because we had to take the mice out of the study because they were so sick. Again here, disease activity much higher, histology activity much higher, and tumor burden much higher. Here you see an example of EDTA-treated mice control group, and here the EDTA-treated mice, and in the IL-10 knockout mice, the same was true here. Totally destructed intestinal mucosa upon EDTA. We studied in T84 cells the tight junctions, cadherin and desmoglobin, to see what happens upon EDTA treatment, and the intestinal barrier breaks down, of course, on inflammatory parameters, inflammatory cytokines like TNF-alpha or interferon gamma, but also on EDTA itself, and the combination is most severe. This you can see also here on the FITC-dextran permeability, and this is in vivo permeability on confocal, where we added EDTA in the mice, and this is also seen by electron microscopy. So EDTA is very toxic, while the other iron products, including the iron trimaltol, seem to be quite tolerable and did not cause any unexpected effect. This study was published a couple of years ago. Raiko Stadiev is the first author in that, and it should just give you a little bit of warning that food supplementation, when used by food industry, does not mean that it's really safe. Let's go to the clinical trials with ferric maltol, the so-called AEGIS studies. These trials were done to demonstrate efficacy and safety in the IBD population. We had one trial in ulcerative colitis, one trial in Crohn's disease, and then we had a follow-up trial in both diseases for 52 weeks. This is the trial design. It was a double-blind trial. Patients were randomized one by one. It's quite a significant number of patients that were all anemic. They were not allowed to be too anemic. They had to have a hemoglobin above 9.5 because they were randomized to placebo. Our institutional review board did not allow us to randomize patients with a hemoglobin lower than that because they would be randomized to placebo. Then they were in a 12 weeks treatment phase, and then the anemia and iron status was evaluated. The primary endpoint was the change in hemoglobin between baseline and week 12. And then there was the follow-up open label trial where all patients received Ferric Maltol. I have to say Ferric Maltol was given at a dose of 30 milligrams twice a day. You will wonder and compare this to trials with ferrous sulfate, where doses of 200 milligrams or more per day are given. And this is the result. Primary endpoint hemoglobin increase. You see a very nice change upon the active drug from average 11 to over 13. And you see also a nice response if you evaluate patients above 1 gram per deciliter. 80% of patients had an increase of over 1. 56% of patients had an increase over 2, and a significant number of patients really increased, let's say 2/3 normalized their hemoglobin. In the follow-up trial, things were as expected. This here shows you the randomization phase that I just showed you. On placebo, there was no response, and these patients were switched then to the active drug, and you see a nice increase in the response also in these patients. Again, the number of patients who normalized on the active compound is up to 92% in this IBD population. When looking into ferritin, things were replicated. Again, in the double-blind trial on placebo, no response on ferritin, and nice increase in the active patients. But what's interesting on this graph is that you see a continuous increase of ferritin in this population for the 52-week prolongation period. So iron is continuously taken up, and we do have a positive iron balance in all these patients. Now let's switch to the adverse events, and I need to point you that this here is a 20% adverse event marker, so this would be 1/5. Of course, nasopharyngitis, these are trials in Europe, and they go over a year. It's very likely that patients feel like me today and become sick and get a cold. I don't think that is related to any of the active drugs. And you also see in the placebo group there is a significant amount of nasopharyngitis. Abdominal pain seems to be a little bit related, but not very much. We had about 8% in the placebo group versus up to 16% in the active group. The same is true for diarrhea. There's a certain amount of ulcerative colitis patients, but not Crohn's disease patients, with a little worsening. But the rest of the side effects basically balance out between placebo and ferric maltol. Also in earlier days, we were already interested in comparing IV iron and ferrous iron. This is ferrous sulfate. These were studies from the first studies from Scandinavia. Stefan Lindgren from Sweden looked into response rate, and on the red here is the IV iron sucrose. That is basically the iron that I used in our first trial in the Annals of Internal Medicine, which I showed you at the beginning. Here, a response rate of 65 to 70%. Oral iron significantly less, but again, this is not the ferric maltol, this is the iron sulfate. I will get to a comparison trial between IV and ferric maltol a little bit later. If you look at the amount of patients which are anemic at the end of treatment with ferrous sulfate, it's over 40%. So the drug is not working as good as it should. We also did a comparison directly, not here with ferric sulfate, but with ferric carboxymaltose. This is the newer drug that we helped to develop. And again, you see a more significant increase on the IV drug than on the ferrous sulfate over a 12-week trial. When we compare various trials with IV and oral compounds, and you lay over the response rate of the Aegis trials that I showed you, you see actually a very nice improvement on the ferric maltol beyond the IV iron. And this was the reason why colleagues in Germany studied the comparison between oral ferric maltol and intravenous ferric carboxymaltose, which was basically the latest drug that we helped to develop in patients with IBD. This was also a randomized non-inferiority trial, and it showed significant, it didn't show any significant difference between the two products. On the first 4 weeks, there might be a little bit more improvement on the ferric carboxymaltose, but everything levels out within 10 weeks in this trial. So you can say ferric maltol is similar to IV iron treatment in this difficult to treat population. So having said that, let me summarize the data so far. Ferric maltol is effective in the treatment of iron deficiency anemia and IBD. In mild IBD, it's comparable to IV iron. It has a favorable safety profile, and last but not least, that's a little bit of a side taste here, bitter taste. Be careful with iron supplemented food. We actually recommend patients to look at food additives a lot and not to use products with food additives.
Wow, thank you. Thank you, doctors.
I promised you to show you the invent
Yes,
LOHA.
yes.
This is Vinita Karen. She's the inventor of LOHA.
Oh, yeah.
I showed you data from Raiko Estatiev. Stephanie Kulnik, unfortunately, is not on this picture. But yeah, you see that the group was proliferative also into the next generations. And I hope they will be proliferative in the future. Let me probably warm up the discussion with two cases. I brought two cases of typical IBD cases. The first is a female, 36 years old. She has 2 children and she is vegan, so almost Indian. And she has extensive UC since 2010, recurrent mild anemia. She was on azathioprine until 2021, and in combination with infliximab. And when we give infliximab infusions, we like to add iron sucrose after the infusion. So it was basically one infusion with infliximab followed by an infusion with iron sucrose. This was done until 2018. Then she decided to get pregnant. So if you look here, this was the area of infliximab and iron sucrose. We were able to stabilize her hemoglobin and to keep her disease. When she got pregnant, she got iron deficient again and had 2 children. And she wanted to restart in 2022 with infliximab. However, she developed antibodies and was not able to tolerate this, so we switched to Entyvio, vedolizumab. This was here at this point. During the induction therapy, we also combined it with iron sucrose. This was here. And then she switched to maintenance subcutaneous Entyvio treatment. And because she didn't need a needle anymore, we added ferric maltol. And what you see on ferric maltol, a nice further increase, and the patient is completely out of anemia during this period of time. Having said that, she has a very good quality of life. She doesn't need IV infusions anymore, and she maintains her good state with subcutaneous biological treatment combined with ferric maltol. The second case is male. He's Crohn's disease using the Vienna classification. Thank you for mentioning this. I really appreciate that. the Vieta classifications, he was A1, L4, B2, meaning that he had upper GI disease, meaning small bowel disease. So he was diagnosed in 2008 with ileitis and 2 skip lesions, 50 centimeter proximal of the terminal ileum. This was followed by resection after terminal ileum, so ileocecal resection, and proximal ileal resection. He started with Humira, adalimumab, continued with infliximab, and developed a stricture at the proximal anastomosis and received stricture plastic. This was in 2020, and if you look here at the hemoglobin at 2020, this was when his iron deficiency started. We often see patients with Crohn's disease on stricture plasters with significant bleeding and very difficult to treat. So in the years to come, he was on IV iron, and if you look at the dose, significant dose, 3 to 5 gram per year. I didn't write per year, this was 3 to 5 gram per year. This was basically total body replacement of iron. If you translate this into blood transfusions, you can say this is about 15 to 25 blood transfusions per year. 15 to 25 blood transfusions per year in the amount of iron. We used several tricks, but at the end we switched to a combination of golimumab and ustekinumab, Simponi and Stelara, at least these are the names in Austria, both subcutaneous, and added Ferric Maltol. And upon this combination, you see a very nice increase and the stop of his anemia. The second thing which we like to do if we reach the stricture plastic endoscopically, we do APC. This is the stricture plastic of this patient. You see here active disease. This was treated by biologicals, but you see also the bleeding. And what I like to do in these cases also use APC for coagulation. I did this twice in this patient, and thereby we solved the problem of anemia. And I think this is the point where we can start our discussion, and I'm happy to take your questions. Thank you very much.
Wow, thank you, Trish, for those wonderful insights. I really appreciate your time and your deliberation. That was really insightful and very highly informative. So I'll open up the entire panel for the question and answers. Now, before I start doing that, let me have some housekeeping rules. So good evening, friends from various centers, those who have joined with me. I would request all of you, I'll call up the name of the center, and I would request you people to restrict 1 or 2 maximum questions allowed per center so that we can have better discussion, and we'll be also restricting our time. Also, I would request that please ask the questions through the moderators. So moderators, please unmute yourself when I call up for your center place. And in the last, we'll have some take-home messages, and then we'll have the final concluding remarks from Dr. Chris. Friends, it's been really intriguing. Iron deficiency anemia, we all are aware that it's a magnificent thing. And if you really look at the amount of the red blood cells which are synthesized or manufactured in the bone marrow, it technically boils down to almost 173 billion RBCs every day are produced. That is almost 21 times of the global population and 121 times of Indian population. That happens in bone marrow. And one of the primary things which drives that is iron. So I'll first come to our center from Behrampur, Odisha, and if we have Dr. Deepak Kumar Prushti to ask this question or two from the center. Over to you, Behrampur, Odisha. Anybody from Behrampur, Odisha? Can you unmute yourself, please? Please unmute yourself. The center has to unmute them. please unmute.
Hello.
Yeah, you are audible now.
Hello. Good evening.
Good evening, sir.
Myself, Dr. Deepak Kushti from Barampur, Odisha.
Good evening, sir. Pleasure.
We want to know about the dosage schedule of this megaferrin. How it doesn't affect the gastric mucosa, and what is the cause?
Fantastic. So the question, Chris from Behrampur, Odisha is, what are the dosing schedules that you recommend and why it is different than the regular traditional iron preparations that we use in our day-to-day clinical practice?
Exactly.
So the dosing which we use in studies is also the dosing which is packed, which is 30 milligrams per tablet. In the studies, we used it twice a day. In clinical practice, we use it typically once a day if patients are not severely anemic, and if patients are significantly anemic below 10, we also use it twice a day. I think the main difference is ferric versus ferrous, and I tried to show you that ferric iron would not induce the Fenton reaction while ferrous iron does. Having said that, of course, iron can change from the ferric to the ferrous condition, and thereby it can also harm a little bit, which you see on the adverse events, but I think it's much more safe than using ferrous iron.
Is it that ferrous form is not interfering with gastric mucosa?
Please repeat your question.
Yeah, so I'll repeat his question. He wants to know whether ferric form gets absorbed better and is not inhibited by the gastric mucosa or a presence of gastric acid. Am I right, sir?
Yes.
About the acid, I don't know, I have to say. And whether it absorbed, it's definitely absorbed better during inflammatory states. When hepcidin is active, ferrous iron is really badly absorbed. The absorption rate are extremely down, while ferric iron can be continuously absorbed. The absorption process of ferric iron is not perfectly understood. It's a very small molecule, and people think that it can transmigrate the mucosa without absorption using the typical iron absorption pathways.
So in fact, Chris, to elaborate a little better on that, we have been always taught in our residency days, when we were taught about iron deficiency, iron absorption, it was always told to us that in the presence of this dimetyl transferase and maybe probably some vitamin C or ascorbic acid, where ferric gets converted to ferrous form and then it gets absorbed in the intestinal mucosa. You mean to say that ferric maltol, rather than following the traditional iron absorption path, bypasses the whole system and has an ability to get absorbed without getting even converted to ferrous form and directly get absorbed and get through the ferroportin to the airport, means transfer it into the straight with the liver and bone marrow, right?
Yes, that is the hypothesis. It has not been proven, but it seems that in this ferric trimaltol form, iron is absorbed bypassing DMT1 and ferroportin.
Perfect. Thank you very much, sir. And thank you.
Just 1 minute. Is it sufficient? This 29 milligram of elemental ferric maltol is sufficient?
30 milligram is definitely sufficient, yes.
Sorry, 1 minute. Today's presentation is on this megaferrin, ferric maltol. It is prepared, I think, best for this inflammatory conditions. What about non-inflammatory conditions? Is it the same, the drop prepared in those conditions also? Number one.
Yes.
Number two, doses. Is it varies from pediatric and geriatric group? Okay.
So first question, in non-inflammatory conditions, it's also highly absorbed. We also like to use it in women. We use it in pregnant women. And in children, I don't know because I'm not a pediatrician. But I guess because of the safety, I don't see any problem also using it in children.
Right. But to extend to that, to your answer, sir, I would say that maybe probably, in a traditional non-inflammatory iron deficiency anemias, you do have got other therapies as well. But this therapy can be also used, but it has a strong advantage where the traditional iron preparations, they fail. Probably, Ferric Maltol has an edge when you are dealing with additional inflammatory challenges, and that is generally a problem. Not only it is a problem with the iron absorption, but there is also a problem because of the excessive hepcidin levels. So there are problems with the iron metabolism also, and that leads to what he was trying to allude to, what we call it as Fenton reaction, where you'll realize that generally in iron deficiency, what we find out that you diagnose it when the serum ferritin levels are very low. But generally when iron deficiency is associated with the anemia related to the chronic disorders, you'll always find out that the serum ferritin levels are above 100. And that tells you that this is the indication where you should not be using iron therapies to manage iron deficiency. Am I right, Chris?
I would say so, yes.
Yes. Thank you, Odisha Center. Now I'll come to Pune Center, to Dr. Dnanoba Bhaskar, a consultant physician and diabetologist from Pune, Maharashtra. Sir, your questions, please. Pune Center, please unmute yourself.
We don't have question from audience till now, but I would like to ask one question to Professor Christopher.
Yes.
In clinical practice, how to use the hepcidin level to differentiate the anemia?
Oh, nice.
We're not measuring hepcidin. It's a very simple question. We're not measuring hepcidin in clinical settings. Hepcidin measurement has not been introduced into clinical practice because it's quite difficult to get reliant data.
Absolutely, and it is an acute phase reactant. So hepcidin levels, they get affected by so many other external factors as well. So in fact, in the research settings, yes, we do have got, but we have simpler tests to know, right? You can do the transferritin saturations, or even you can do the serum ferritin levels, apart from the serum iron levels that you hold that. And some laboratories will also give you the ratio of log transferritin versus log ferritin. That will also help you in differentiating and diagnosing the iron deficiency anemia and the related challenges.
Okay, and next question. Generally, we give once a day dosing, means in the fasting state or 2 hours after the food. But you said that this can be given, Ferric Maltol can be given twice a day. So does it affect hepcidin level, this absorption of iron, giving twice a day?
We don't know that. We designed the trials using it twice, 30 milligrams, because we were optimistic that 60 milligrams a day would be effective enough. And yes, 60 milligrams a day were very effective in the trials, as I showed you. In clinical practice, as I mentioned before, for mild anemia, we currently use it only once a day. 30 milligrams only. For significant anemia, we use it twice a day. I can't tell you, whether it affects hepcidin levels because it has not been studied. Coming back to your question before, actually, what I rather use instead of hepcidin is really standard markers of inflammation, such as CRP or blood sedimentation rate, to judge the amount of inflammation and to judge the amount of iron absorption problems in these patients. When patients have high CRPs, you have to be aware that you get significant absorption problems.
Yeah, so to continue with the same question, Chris, I want to know, do you still recommend people to stay away from the calcium preparations or dairy products before administration of even Ferric Maltol, which is generally a traditional practice when you are prescribing an iron? This is a clear-cut instruction those are issued to the patient, that please avoid taking it with food, and especially food with dairy products, and do not combine it with the oral calcium therapy.
No, we recommend taking it fasting, and we recommend We don't recommend not taking dairy products when they're on iron treatment. Iron treatment has to be a continuous treatment for months, even years, and we would not reduce dairy products in our patients.
Thank you, Pune Center. Now I'll come to Warangal, to Dr. Chandrasekhar. Dr. Chandrasekhar from Warangal. Please ask your question, sir. Please unmute.
Sir?
Yeah.
Yes, sir.
Yes. Good evening, sir. Yeah, you are audible. Good evening, sir.
Good evening, sir. So happy to see you, sir. And also it is very happy to hear from Professor Christoph Gash regarding this very important topic, sir. So we center, we have one question that what Professor Christoph shown in one this thing. So the study has compared with the placebo. Not compared with any other iron preparations one, and there is no IV comparison. So that is one question, sir. Second thing is that anemia of inflammation is different from anemia of the iron deficiency.
Excuse me, some
Because it is not true deficiency.
I don't understand anything. I'm sorry.
Professor Christoph.
I am able to understand, Chris, about this, so I'll ask. But before that, I would request the technical team to please mute all other people, those who are talking in the background, please. Please, everybody, I am requesting you guys to keep yourself on mute when somebody is asking the question. So the question is primarily as far as the AG study is concerned that you showed. How about the comparison of this drug with the injectable preparations or IV preparations? Number two, he wants to know that most importantly, when you will say that this is the time to shift from oral preparation to an injectable preparation, is there any or something called as a treatment failure? And he wants to ask also that iron deficiency because of the chronic diseases or chronic metabolic diseases or chronic challenges, it's completely different. That we know it as an iron, the anemia of the chronic disorders, and there, is it comparable with the traditional iron deficiency anemia? So these are two questions that he wants. Am I right, sir?
No, right, sir. Right, sir. Actually, because in this one anemia of inflammation, there is entrapment of this iron by the macrophages, so there is no true deficiency of the iron, sir.
Yes.
So you are nicely narrated the question.
So that is the place where probably the role of hepcidin and its interference with ferroportin comes into the picture.
Yes, sir. Yes.
So, most of the iron gets deposited in the reticuloendothelial system and maybe probably the intestinal cells, and it is excreted unabsorbed. So, over to you, Chris.
So first question, comparison to IV. There is only this single trial that I showed you from Germany that compared ferric carboxymaltose to ferric trimaltol. So injectable or intravenous treatment versus oral treatment, which was very comparable. For clinical practice, if patients are very sick and have severe anemia and you have IV treatment available, I would use IV. And if the patient is also able to come to the center and get the infusion. I know India is a large country and patients live apart from doctors who are able to give infusions. So I think for patients who have a it's a very good molecule for maintenance, for long-term treatment, where patients don't want to get infusions.
Thank you very much, Chris. Thank you, Warangal Center. Thank you very much for being there. Now I'll move on to now Jorhat, Dr. Sujoy Barua from Jorhat. Sir, question from your place. Do we have anybody from Jorhat?
Jorhat is muted.
Yeah.
Hello.
Yeah, you are audible. Yeah.
Okay. Actually, from Jorhat, I would like to ask, in Assam, we used to get anemic patients, very severe anemia, 6.5, 6, 7, in that range. Whether this Ferric Maltol, you have any studies related to low, very low iron, which respond to Ferric Maltol?
Yeah, so question is that is this molecule useful to manage very severe anemias where HbE hemoglobin is less than maybe probably 7?
Yes, so we do in clinical practice, I mentioned before, we do treat patients with severe anemia intravenously to make sure that also the compliance issue is not there. The patient is getting iron 100% intravenously. If this is not possible for various reasons, I do think this is a very good compound. I would use it twice a day in these patients and try to control the response in shorter periods of time to make sure that the absorption is appropriate and the response is appropriate.
So in fact, shall we draw a conclusion that generally if the anemia is very severe, ideal to start with the parenteral iron therapy first? Correct?
I would do so. Yeah, I think it's, if you want to be on the safe side and if the patient wants to be on the safe side, we use IV for number one for compliance, number two for there is no issue about absorption. The drug is 100% in the body, and we don't need to worry about whether it gets into the body or not. So the bioavailability of IV is 100%. The bioavailability of oral drugs is never 100%. The bioavailability of ferric trimaltol is significantly better compared to ferrous products, so I would prefer that product over others in the IBD population. But yes, in Austria, patients are living very close to doctors. I don't know how many gastroenterologists or how many doctors per capita is in India. In Austria, we are one of the countries with the highest number of doctors per capita, and so patients with significant anemia always get IV iron therapy.
Fortunately, in India, we do have that lot of disproportion between the patient and the doctor. So, and we are working on it, and I'm more than sure that in coming times we are going to do it much better, honestly speaking. So, Chris, in Aegis study that you showed, where their population people were involved with severe anemia versus mild anemia, and was there any difference in the response or the delay in the response?
So I mentioned that in the Aegis studies we were not allowed to include patients with severe anemia because they were randomized to placebo. Our ethics committee would have considered it unethical to randomize somebody with a hemoglobin of 7 to placebo. So this is withholding of active therapy. This is unethical. So this is why patients had a hemoglobin of at least 9.5 when they were in the Aegis studies.
Oh, thank you. I'll come to Dr. Madhulika Agarwal from Jaipur. Thank you for being there, ma'am. It's a pleasure and honor to see you. Please unmute yourself and then ask your question from your center, please. You need to unmute. Yeah.
Hello. First of all, I would like to congratulate Dr. Pillava for such a nice and elaborating lecture on Ferric Maltol. My question is, sometimes the ferritin levels are unreliable. In that case, what is the best diagnostic tool to diagnose anemia?
There's a lot of background noise, but what
I understood that ferritin is unreliable, and what is the best diagnostic tool to diagnose anemia?
Is that right? Yeah.
That is correct. Ferritin is on various levels unreliable. However, a low ferritin is always low, okay? High ferritins are not necessarily showing that there is high iron content in the body. It can be due to inflammation, high ferritins, but a low ferritin is a very good parameter. So if you have ferritins below 30, and this is the cutoff which we are using, you can be very sure that there is significant iron deficiency. If the ferritin is in IBD patients around 50 or 100, and you see also CRP levels elevated, I would still consider this as a standard of using iron therapy, because these patients are likely also iron deficiency. The most important parameter for us is hemoglobin. It's the simplest parameter, and it's the biological most important parameter. So if the hemoglobin is low and the ferritin is not high, let's say that is not above 200, we would definitely supplement patients with iron, sometimes in combination with erythropoietin, sometimes in combination with biologicals, sometimes in combination with steroids, whatever the patient needs for controlling the underlying disease. But iron is basically the standard of treatment in all anemic patients.
Yeah,
With very few exceptions, as I mentioned, yes, there are some patients with vitamin B12 deficiency, but for vitamin B12 deficiency, you see a high MCV. If
Yes.
that MCV is high, you probably don't think about iron deficiency that much. If the MCV is high and you have the patient on azathioprine, it's probably likely due to the azathioprine and not to the iron deficiency. But in other cases where the MCV is not high, I would go for I apologize for iron treatment.
Yeah, so that means that, ma'am, generally the traditional guideline-directed medical approach to investigating anemia. First, look at the MCV, simplest thing that you will do, and you will get on the CBC. If MCV is more than 100 femtoliters, you are almost ruled out iron deficiency. Now, if MCV is less than 100 femtoliters, then you might as well use the investigations like serum ferritin. Now, if serum ferritin is less than 30 micrograms per liter, and also try and use in combination with serum ferritin the transferritin saturation levels. If serum ferritin as well as the transferritin saturations are low, and if transferritin saturations are less than 20, that establishes the diagnosis of iron deficiency. Now the challenge starts generally when the serum ferritin levels are in between 30 to 100. Now that is the place where transferritin saturations can come to your rescue. There, probably, if transferritin saturations are less than 20%, you know that there is a coexistent iron deficiency anemia to possibly iron deficiency of chronic disease. And that generally can be confirmed by asking your laboratory to do the transferritin receptor versus the log ferritin ratio. And if that ratio is more than 2, you almost know that it is an iron deficiency combined with anemia due to chronic disease. And where
Magesh, you summarized everything perfectly well, but may I just mention that iron treatment is so simple, is so straightforward, and laboratory parameters are biomarkers for something. I would rather go and treat and not do more laboratory parameters.
Yeah, fair. It's, what Chris is trying to say, that, treating is more cheaper and easier than maybe probably asking for the investigations. Am I right, Chris?
Yes, that is what I wanted to say.
Thank you very much. Now I'll come to our next center, and that would be, from Ranchi.
From Jaipur, there's one more question. I think the lady wanted to.
Is it? Oh, I'm so sorry. Yeah.
The maximum dose of iron we can give in a woman who is pregnant and suffering from iron deficiency. Say her hemoglobin level is 5 grams only, and she is not getting blood transfusion. So, what would be the highest dose we can give in such patients?
Nagesh, did you understand?
Yeah, so she wants to know what is the maximum possible dose that you can give of maltol to the patients, where patients do not require transfusions.
We never used more than twice 30 milligrams. and there's no data out there that supports it. So I would not go over twice 30 milligrams, though I'm sure that if you use higher doses, you won't find significantly more adverse effects. So I think it's a safe drug, but I would not go beyond 60 milligrams a day.
Perfect. Thank you. Thank you, Jaipur Center, for those lovely questions. Now I'll come to our next center, that is from Ranchi, and we have Dr. Beauty Banerjee, surgeon from Ranchi. Madam, can you ask your question? Unmute yourself and ask your question, please. Yeah, you are unmuted. Please ask your question. You are not audible yet, ma'am.
Good evening, sir. We
Good
see
evening,
a
ma'am.
lot of patients of sickle cell anemia in our daily practice. Can we give Ferric Maltol in those patients?
Very good question, which I can't answer because I never saw a patient with sickle cell anemia myself.
Oh my
We
God.
don't have these patients in Austria.
Okay. Okay, sir. I'm asking then a second question. What is the
Let me elaborate. If a patient with sickle cell anemia has iron deficiency, I'm sure you can give it. You have to make sure that there is also iron deficiency. There is a lot of patients with combined anemias. You know, you have a combination of inflammation and a combination of iron deficiency. You have a combination of a genetic disease like sickle cell and iron deficiency. You take out one of the causes of anemia and you improve it. I'm sure iron products would not make sickle cell anemia worse.
so we can give it, sir?
Yeah, if the ferritin is low. If the sickle cell anemia causes a lot of hemolysis and you have high ferritins, I wouldn't do it.
If the ferritin is normal, sir, can we give it?
What is normal in your understanding?
If it is more than 30?
Yeah, I would say if it's below 50, you can give it. If it's below 50 and you don't see a CRP, if there's a CRP elevation because of another underlying disease, I would give it, yes.
Thank you, sir. So one more question. What is the minimum age of giving Ferric Maltol?
I said, you know, in clinical trials, we used only adults, and there is, as far as I know, no studies in pediatrics. However, having said that, I would not be cautious so I would not be worried to give it to children as well. I think it's very safe.
Thank you so much, sir.
Thank you, ma'am. Thank you, Ranchi, for these wonderful questions. Now we'll come to our last center, that is Kolkata. Do we have anybody from Kolkata to ask the question, or shall I ask on your behalf? Anybody from Kolkata?
Hello,
Yeah, good evening, sir. You are audible. Please ask your question.
I have a question.
Yeah.
We see lots of cases other than
You are muted again, sir. Please unmute yourself. Kolkata Center, you need to unmute yourself. Tech team at Kolkata, please help them to unmute.
Very interesting questions are coming up here, I have to say.
no. I think I am audible now.
Yes,
Yeah,
you are.
Please start the question.
You have talked about inflammatory bowel disease, but we see other cases also like CKD, tropical sprue, and anemia of chronic disease. What is your opinion whether this Ferric Maltol can be used? And the second question is, as a clinician, what should we know about FCD? Is it to be checked prior to giving this kind of medicines?
Question number one, I think it's good to say that other inflammatory diseases, also chronic kidney disease, would nicely respond to ferric trimaltol. There is no reason to believe that it would not work in these patients. Regarding the question Hepcidin, I don't think that any clinician needs to know a lot about hepcidin. I think what you need to know is and this has been said during the discussion and also in my talk, that under inflammatory condition, absorption and release of iron is a problem. And this is why patients don't respond as well to iron supplementation therapy. But I don't think that there is any point to measure hepcidin or to know something about it. I think it's a very interesting molecule, having said that, because actually it's an antimicrobial peptide. It has been discovered in the early 2000s as an antimicrobial peptide in the urine. So this is how how scientists came about hepcidin. And so this hepcidin has an iron regulatory property and has antimicrobial properties in the body. So I think it's a very, very interesting peptide, but as a clinician, I don't think you need to know a lot about it.
Thank you.
And what about tropical sprue?
Tropical sprue.
You're asking me questions for patients I've never seen. So we don't have tropical sprue in Austria. I'm sorry.
Equivalent in India.
Yeah, you know, we do have sprue in Austria, a lot of sprue in Austria, and as soon as celiac patients start with a diet, gluten-free diet, they absorb iron again, and yes, in these patients you can use it. In tropical sprue, I guess the situation is similar. Iron absorption is blunted through iron malabsorption. So if patients have tropical sprue, active tropical sprue, I think the absorption will be minimal.
So is this the place you consider injectable therapy?
Are these patients highly anemic? I don't know. Are these patients anemic? Tropical sprue patients.
Minor cases.
So he wants to know about thalassemia minor.
Thalassemia.
Oh yeah, thalassemia minor, we have a lot in Austria, and these are one of the issues. There is a lot of thalassemia cases with iron deficiency. Patients always think they have iron overload. No, if they are minor cases and they're women or they have other underlying disease where they are bleeding, then you have to support them with iron. And yes, for these patients, a very good product.
Thank you, Kolkata Center, for those wonderful questions. Now, finally, before we, have one final take from Chris, my last question, Chris, would you still recommend Ferric Maltol as the first line therapy? Would you put it as a second line therapy after the traditional iron preparations? Or you would still continue to say that, wait for the oral other preparations, then come in? And would you put it ahead of the injectable therapy?
I can only say what's our standard. In our world, we are not using ferrous products anymore. Ferrous products in IBD are gone. I have not seen any doctor prescribing a ferrous product in IBD in years. Even other doctors, when I see patients coming in, there is no IBD patient taking ferrous products anymore. So the only two ways to supplement iron in IBD is either intravenous or ferric maltol. That is the practice. And as I said, the very severe ones, they always get IV, because in Austria, the way to the next doctor is a maximum of 20 minutes. And those with mild anemias and long-term treatments, they're on ferric maltol.
How about in non-IBD situations?
In non-IBD situations, it's limited in Austria because of prescription limitations. Insurance wouldn't pay for it.
Yeah. Okay. Thank you, Chris, for this wonderful insight. So, friends, I think that's it for last 1.5 hours that we had a terrific discussion on iron deficiency as a whole and the role of ferric maltol, which is a new molecule in India. I'm really happy to announce that now it is easily available in India. So before I wind off, I would request a representative from Aristo Pharma and Medica Press to say final words and word of thanks. Maybe I'll hand it over to Sanjay and then Ramnath for the concluding remarks.
Thank you very much, sir. I would like to express my sincere gratitude to Professor Gesh for sharing his extensive experience with our audiences today. And also Dr. Tevaskar, your rich clinical experience was quite evident in the way you moderated the session today. I would also like to thank all the participating delegates and the connected centers for raising the level of the discussion and very interesting questions for discussion that you have raised. And last but not the least, would also like to thank Aristo Pharma for that continuous support in making such scientific exchanges possible. Thank you very much, everybody, for joining today.
Thank you very much. Good night, everybody. Stay happy, stay healthy. Chris, once again, best wishes to you from India. And we wish to see you future more and more in our different updates and CMEs and webinar. And we would love to see you in person sometime whenever we get an opportunity. I would like to visit your center if it's possible.
Maybe. I'm looking forward to it again. I'm always impressed, I have to say, about the high level of knowledge of medical doctors in India. It's astonishing how high the educational level of doctors in India is. I'm really impressed.
Thank you. So good night, everybody. Thank you. Stay safe. Stay happy. Bye-bye.
Thank you very much, sir. Thank you, everybody. Thank you.